Good evening, students. Welcome to you from Sri Rama Hospital, Jagapet. I'm continuing the topic of acute pancreatitis. In one of the previous classes, I have discussed about the pathophysiology and clinical features of acute pancreatitis. Hope you reviewed it. So we will continue from that where we have stopped there. Is it okay? Or shall we have it from the beginning? We have finished pathophysiology and clinical features, and only just investigations we have touched upon. So do you want from the beginning? Okay, it will take another total means it will be 1 hour. So just I will give a glimpse of the past topic. Is it okay? Okay, you just go through this, and if you have any doubts, I will again go back and clarify them. Acute pancreatitis is not due to infection. It is due to autodigestion of pancreas by the activated pancreatic enzymes, namely trypsin and lipase. These two enzymes, they are being activated when they are in the acini of the pancreatic. The activators of trypsin, trypsinogen and lipase are trauma to the pancreas, bile reflux into the pancreatic ducts due to a gallstone blocking in the ampulla of water. This is called the common channel theory. That means when the stone gets impacted at the papilla of water, then the bile refluxes into the pancreatic duct. And this bile activates the trypsinogen to trypsin. Or it may be due to direct action of the alcohol. 80% of the cases are due to alcohol or gallstones. Rare causes are due to hypertriglyceridemia, hypercalcemia, mumps, drugs, scorpion sting, and following surgery in and around the pancreas or following ERCP procedure. So whenever you meddle around pancreas, the enzymes can be activated. So due to activation of these enzymes, that means the amylase and lipase, they cause autodigestion of the pancreas, leading to edema of the pancreas. If it becomes severe, it causes hemorrhage, still severe necrosis, and later superadded infection causing infected necrosis. So these are the 4 stages that you see in the pancreas: edema, hemorrhage, necrosis, and later infected necrosis. These are the 4 stages of the acute pancreatitis. There will be seepage of pancreatic enzymes from the digested pancreas acinar cells into the peripancreatic tissues, spreading in the retroperitoneum, causing widespread fat necrosis and hemorrhages, and to the mediastinum, producing ARDS. So there will be seepage of these enzymes from the pancreas in the retroperitoneum, and these exudates, they spread in the retroperitoneum. Because they have a lot of enzymes, the active things are being the lipase and trypsin, they cause digestion of the fats and digestion of the protein substances in the retroperitoneum. That means every tissue in the retroperitoneum can be digested by these enzymes. So it causes widespread necrosis, hemorrhages in the retroperitoneum, and through the aortic orifice and esophageal hiatus, these exudates, they spread into the mediastinum, producing mediastinitis, as well as pleural effusion, pneumonitis, and ARDS. That means adult respiratory distress syndrome. Apart from the local spread of the exudates in the retroperitoneum and mediastinum, there will be systemic absorption of these enzymes. So they will be absorbed into the bloodstream and they cause activation of inflammatory mediators. So when inflammatory mediators are activated systemically, it produces systemic inflammation. That is called the SIRS, Systemic Inflammatory Response Syndrome. That means there will be generalized vasodilatation of the vessels. So there will be generalized vasodilatation of the vessels, and there will be fluid exudation into the tissues, and loss of function or decreased function of the tissues, organs. So when the systemic involvement of the body with inflammation, that leads to MODS, that is multiple organ dysfunction syndrome. So pancreatitis is not a localized disease. It starts as a localized disease. Later, due to spread of the enzymes in the retroperitoneum, it causes some changes. Because of the absorption of the enzymes into the bloodstream, it just check the mic once. Okay, now I think it should be good. Just see if there is any problem. I will try to do something else for this. The voice should be good now. So there will be systemic absorption of the enzymes leading to SIRS and MODS. So because of the local spread of exudates and enzymes, there can be pseudocyst formation, abscess, and ascites. The general complications due to acute pancreatitis are due to multi-system and organ dysfunction as a result of systemic inflammatory response syndrome. So that is the pathophysiology. The clinical features, these are due to local changes in the pancreas, manifesting as severe pain in the upper abdomen, radiating into the back, relieved by stooping, usually 1 to 4 hours following a heavy meal or alcohol intake. So the patient gets so much severe pain that it is described as illimitable agony. In severe cases, due to peripancreatic seepage of enzymes, it manifests as bluish discoloration of umbilicus. This is called the Cullen's sign. There is nothing but hemorrhages in the subcutaneous tissues around the umbilicus, or as ecchymosis or subcutaneous hemorrhages in the flank. This is called the Gray Turner sign, along with features of peritonitis. That means there will be abdominal guarding with tenderness and abdominal distension. So this is in severe cases. In mild cases, there will be only pain. On examination, you find mild tenderness, but there is no guarding. There are no features of any bluish discoloration or ecchymosis in the flanks or in the abdomen. There is no abdominal distension in the mild case. Due to systemic absorption of enzymes, severe cases manifest as shock. The shock can be due to fluid sequestration, that is called third space loss, paralytic ileus, neurogenic shock, and septicemic shock. The patient can also manifest with ARDS, that is as tachypnea, cyanosis, reduced PaO2 with hypercarbia, disseminated intravascular coagulation, hypocalcemia, severe paralytic ileus, renal failure. These are all the general manifestations or systemic manifestations of the acute pancreatitis due to SIRS. Acute pancreatitis should be differentiated from all causes of acute abdomen, from myocardial infarction, and from basal pleurisy. So this is what we have discussed in the previous class. Now, let us go to the investigations of a patient with acute pain abdomen. So whenever a patient comes to you with acute pain abdomen, you have to take certain investigations. Number one, to diagnose acute pancreatitis, you have to do biochemical investigations. You have to do imaging, that is with X-ray, ultrasound scan, CT scan, MRI scan, then ERCP. If they are not giving any information, you have to go for laparotomy in certain cases where severe acute pain abdomen with systemic disturbance is present to differentiate it from acute midgut ischemia and gangrene. Then the second step is, once you diagnose acute pancreatitis by these investigations, then you have to evaluate the severity of the acute pancreatitis. Is it mild disease or severe disease or moderate disease? This is done with the help of Ranson's criteria. So already we discussed these things. That's why I will go a little bit rapidly here. Estimation of serum amylase. Normal is less than 100 Somogy units or less than 180 international units. In acute pancreatitis, amylase rises in 4 to 6 hours and reaches 4 times above normal and declines within 4 to 8 days. So amylase rises in 4 hours, reaches 4 times normal and declines in 4 days. It helps in diagnosis only, but has no prognostic value. That means, no prognostic value means if the level is 1000 or if the level is 5000, because it is very high, we need not think that it is a severe case. Severity of the case is not judged by the level of amylase. It is judged by other parameters. Amylase helps only in making the diagnosis of acute pancreatitis, not its severity. Elevated amylase excreted in the urine, so urinary amylase is elevated, and these levels persist for up to 1 week after cessation of rise in the blood levels. It has also false positives in these following cases. That is why, because elevated amylase is there, so every case need not be dubbed as acute pancreatitis. You must take the other investigations like imaging also into consideration. Lipase, it is useful to diagnose the condition even if the patient presents later than 4 days. Amylase presents only for 4 days. After 4 days, it is not there. That is why even if it is there, patient comes to you after 4 days also, you can do serum lipase estimation and you can make the diagnosis. It is more sensitive and specific. Serial assessment of C-reactive protein. It is a useful indicator for the progress of the disease. That means when the patient comes to you, you do CRP. If the CRP is 200 milligrams per liter, then you do it again after 2 days. If it goes by 400 or 600, that means that the disease is progressing. If it comes down to 100 or 70 or 80, something like that, means it is decreasing. So you can gauge the progress of the disease by doing CRP. A peak CRP of more than 210 milligrams per liter in the first 4 days predicts severe acute pancreatitis. Then imaging studies, plain X-ray abdomen. I hope all of you have seen this X-ray. You remember this. What do you call this sign? You are seeing two black shadows here. One upper one, second one is the lower one. The second one is stopping here. This black shadow is exactly stopping here. What do you call this sign? No, it is not double bubble sign. Yes, good. It is called colon cutoff sign. Because you mentioned double bubble sign, tell me where do you see double bubble sign? You must have read the some other topics in abdomen. Ah, wonderful. Excellent. You are right. It is dual atresia. Dual atresia, you get the double bubble sign. Very good. So plain X-ray abdomen to exclude perforated peptic ulcer, enteric fever, etc. Bowel loops adjacent to pancreas shows ileus in C loop and transverse colon as horizontal band of gas. This is called colon cutoff sign. Here and there you can see the sentinel loops of gas, but these are not of much use. If such is there, you can't say it is acute pancreatitis. Sometimes you may find kidney shadows. Around kidney shadows, you will find a halo. That's called renal halo sign. Ultrasound scan is not very useful. The swollen gland is visualized in only 25 to 50% of the cases. It helps in demonstrating associated biliary tract disease like gallstones or dilated common bile duct. CT scan, the most useful diagnostic investigation to diagnose the disease and its extent. So whenever a patient with acute pain abdomen comes to you, you take plain X-ray abdomen in the erect posture to see for any gas under the dome of the diaphragm. Then you estimate serum amylase. If amylase is elevated, then that means at least 4 times the normal. That means if it is more than 500 or 600 international units per liter, then you can safely make the diagnosis of acute pancreatitis. So acute pancreatitis, we have seen stages. Stage of edema, stage of hemorrhage, stage of necrosis, stage of infected necrosis. So there are 4 stages. So what is the pathological stage of the pancreas? That can be evaluated by doing a CT scan. So it is one of the most important and useful diagnostic investigation in the diagnosis of acute pancreatitis. If there is pancreatic necrosis, it is seen as decreased pancreas enhancement following intravenous injection of the contrast. Presence of gas indicates infected necrosis. Involvement of colon, blood vessels, and adjacent structures are identified. So these things can be evaluated on CT scan. This is CT scan of the pancreas, which shows the fat stranding surrounding the edematous pancreas. So whenever there is fat stranding, that indicates that there is edema of the fat. So around the pancreas, there is fat stranding. The first stage, what you see is the edematous swollen pancreas. So as it becomes more edematous, it becomes more hypoechoic. And there is fluid collection. You can see fluid collection around the kidneys. So this is the edematous pancreas. This is the duodenal wall. The duodenal wall, this is the duodenum, C loop of the duodenum. This is the stomach. Stomach wall is normal, but duodenal wall is edematous. They are swollen. Now, if you compare the previous, this X-ray, this CT scan, where you see white granules are more, but in this there is rim of white tissue here, with central occupied by more of black granules. Black granules indicate that there is a lot of fluid. If it is pure black like this, then we say it's collection of fluid, collection of water-like fluid. But this is having white material inside. That means it is something like pus. So that means it is a infected necrosis. So to evaluate whether the pancreas is having necrosis or not, what you must do is you must take a scanning before giving contrast and after giving contrast. You can see here, this is before contrast. You can see the edematous pancreas here. So when you look at this, our diagnosis will be only as acute pancreatitis. Then intravenous contrast is given and you take the X-ray after about 2 or 3 minutes. Then you can see these areas have become enhanced. That means they have become more brighter. But this area has become black because the area which has taken the contrast will show as the enhancement. Which area will take up the dye? Whichever is having the perfusion. So this part of the gland is having normal perfusion. And this part of the gland is having no perfusion. When there is no perfusion, it looks black. So we can say here that this is the necrotic pancreas. So that is why a pre-contrast X-ray and post-contrast X-ray are essential. You can see in the post-contrast, the kidneys have become enhanced. So all the structures which are perfused by the dye will be enhanced. This is again a necrotic material in the pancreas. The indications for CT scan: diagnostic uncertainty in cases with severe disease manifestations to identify necrosis and infected necrosis. So the patient comes to you with severe disease, where there is abdominal distension, where the patient is having hemodynamic shock and ARDS or etc. etc. That means systemic sequelae. Then you must take the CT compulsorily in this patient to see whether there is necrosis or infected necrosis. And every 2 days or 3 days, you have to repeat the CT scan to see for the progress of the disease. So whether the disease is advancing or regressing. So that is in patients with organ failure, in cases with progressive deterioration, in cases with local complications such as fluid collection, pseudocyst, and abscess formation. This is this CT severity index. Of course, this is not necessary for you. This is important for the radiologist and for the surgeon who is treating these cases. So pancreatic inflammation can be graded on CT scan. Just enlargement of the pancreas, peripancreatic inflammation with peripancreatic fat stranding, pancreatic fluid collection, more than 2 acute peripancreatic fluid collections, then pancreatic necrosis. So these are the stages of the pancreatitis on CT scanning. So there is scoring for this. So how much score the patient gets, by that you can assess the severity of the patient. ERCP is done only in patients with gallstone pancreatitis. That means when you do ultrasound scan, when you notice stones in the bile duct or dilated CBD, that indicates that there is a stone in the common bile duct. So this pancreatitis may be due to gallstone pancreatitis, due to bile reflux. So in that case, what you do is you do ERCP to confirm the diagnosis. If it is bile reflux is present, then you must do some surgery to remove the stone. Unless you remove the stone, the pancreatitis will not be resolved. So you have to do the ERCP and take away the stone. MRCP is non-invasive and useful to detect CBD stones and pancreatic duct anatomy. So MRCP has no therapeutic value. So because non-invasive, you can detect these stones easily. Laparotomy and laparoscopy indications: if other causes of acute abdomen cannot be excluded. Findings in acute pancreatitis: once you open the abdomen, you will find widespread fat necrosis of the omentum, blood-stained peritoneal fluid, edematous or hemorrhagic or necrotic pancreas. So these are the fat necrotic nodules. They look like something like paraffin wax, and you can see blood-stained fluid in the peritoneal cavity. So that is to diagnose acute pancreatitis. So the main diagnostic feature is by CT scanning. CT scan is not done in every case of acute pain abdomen. So the first investigation you do is the urine for microscopic examination. Then you do plain X-ray abdomen in erect posture. Then you do ultrasound scan. By reviewing these X-ray, these investigations, and of course serum amylase estimation. So these things must be done in every case. I repeat, urine for microscopy, plain X-ray abdomen, ultrasound scan, serum amylase. So these things must be done in every case of acute pain abdomen. If it is acute pancreatitis, the ultrasound scan may show dilated or enlarged pancreas. Serum amylase will be elevated. So once serum amylase is elevated and there is pancreas, patient is developing distension of abdomen or developing systemic signs of acute pancreatitis, then you have to go for CT scan. CT scan will tell you whether it is stage of pancreatitis, edematous, hemorrhagic, necrotic, infected, necrotic. Then you can follow up the progress, how the disease is progressing. So with that, we will confirm the diagnosis. Once you confirm, then you have to evaluate severity of the pancreatitis. This is done with the help of Ranson's criteria. This is very important question, so you should know about this Ranson's criteria. Ranson's criteria means these are a set of investigations to evaluate for systemic disturbance of organ dysfunction. So is there any organ dysfunction? So you do the investigation for all the organs and systems of the body. Give a scoring for that. Ultimately, you add up all the scores and you come to a conclusion. How much scoring is there? By that you judge whether it is severe pancreatitis or mild pancreatitis. So it is to evaluate the severity of the acute pancreatitis. The criteria taken are age of the patient. For every positive thing, you give the score of 1. So there are not 1, 2, 3, something like that. For everything, there is only score of 1 only. Age more than 55 years. Total leukocyte count more than 15,000 per cubic millimeter, which indicates a severe inflammatory response. Blood glucose more than 200 milligrams per cent. LDH more than 700 international units per liter. AST more than 250, that means SGOT. Blood urea more than 100 milligrams per cent. PaO2 normally is 90 to 113 millimeters of mercury. So if it is less than 60, you give it a scoring 1. Estimated fluid loss more than 6 liters. Hemoglobin percentage and hematocrit fall more than 10%. Serum calcium levels less than 8 milligrams per cent. Why serum calcium levels fall in acute pancreatitis? Why do they fall? Why calcium levels fall in acute pancreatitis? Yes, good. It is saponification of the fat. So consumption of calcium in formation of fat necrosis. So there is If much of fat necrosis has been formed in the retroperitoneum, large areas of fats have been necrosed. That means large areas of large quantities of calcium have been utilized in the formation of fat necrosis. So whenever there is large quantities of calcium have been utilized, there will be fall in serum calcium levels. So that indirectly tells us about the area of fat necrosis. So to estimate the areas of fat necrosis, serum calcium levels will be helpful to us. Base deficit more than 4 millimoles per liter. What is base deficit? What do you understand by base deficit? No, it is not anion cation gap. Base deficit. What is meant by base? It is nothing but the acid bases as bicarbonate. Bicarbonate is the base. What is normal bicarbonate level in the blood, in the serum? What is the normal level? It is between 20 to 25 as milliequivalents per liter. If it is less than 20, we call it as there is base deficit. So if it is less than 20 by more than 4, that means if it is something around 16, then we call it as base deficit is 4. So if the base deficit is more than 4, that means that the patient is having, it should give a score of 1. Serum albumin less than 32 grams per liter, that means 3.2 grams percent. More than 3 factors at 48 hours indicate severe disease. So this Ranson's criteria is done at the time of admission, and again after 48 hours you do these Ranson's criteria. So just evaluate whether factors are increasing or decreasing. After there is simplified Ranson's criteria, this is called Glasgow criteria. Here the parameters are few, not so many. The parameters are PaO2, ACE, nitrogen level, that is urea, then calcium, raised total count, enzymes LDH, AST, albumin level, sugar level. So in all these investigations, you can notice that there is no amylase estimation. Why? Because amylase is not the parameter to judge the severity. It is only helpful for making a diagnosis. To help for the severity, you have to do these various investigations. So if they are positive, if 3 of them are positive, then we can say the patient is having acute pancreatitis, with severe acute pancreatitis. So severe disease means more than 3 factors. So they simply indicate the systemic organs and systems dysfunctional status. So the investigations are aimed at diagnosing acute pancreatitis, number 1. Number 2, to diagnose the severity of the acute pancreatitis. So you can see here, this is the pathology of the pancreatitis. Gallstones, alcohol, other miscellaneous agents, they cause activation of proenzymes in the pancreas, leading to autodigestion of pancreas and acute pancreatitis. So this is the basic pathology of acute pancreatitis. This leads to pathological changes in pancreas: edema, hemorrhage, necrosis, infected necrosis. Then there will be seepage of fluid from the pancreas into this peripancreatic tissues and causes peripancreatic tissue digestion. Because of this, there will be ARDS, fat necrosis, ascites, and pseudocyst formation. Apart from this, there is also systemic absorption of enzymes and inflammatory mediators, leading to SIRS and MODS. When the acute pancreatitis is only in the first two phases of edema or hemorrhage, it manifests as mild disease. That means patient has only symptoms of pain, severe pain, vomiting. There is no abdominal distension. There is no abdominal guarding. There are no systemic sequelae. This is called the mild disease. If there is necrosis or infected necrosis, it is severe disease. Similarly, if patient is developing any of the organ dysfunctions, that means there is systemic involvement of the disease, then we call that as severe disease. So mild disease and severe disease. These two are because of these changes. I hope this is clear to you. Now, what is the management? The management is nothing but treating the pathological changes that happens in the pancreas and its sequelae. For the mild disease, the treatment is only because patient is having pain, treat him with analgesics, give him IV fluids, admit in the hospital, and you monitor him whether he progresses to severe disease or it resolves simply. A mild disease will resolve within 3 to 5 days time. So if the patient is getting pain or increasing pain even after 3 days or 4 days, means it is not a mild disease. He is progressing. So you must monitor him by Ranson's criteria. If the criteria shows more than 3, that means he is having severe disease, then you must manage him like severe disease. So what do you do in severe disease? ICU management. What is meant by ICU management? ICU management means every organ and every system is monitored regularly, every hourly, every 2 hourly, or every 3 hourly. You monitor. That means you monitor the liver, you monitor the kidney, you monitor the coagulation profile, you monitor the cardiac status, you monitor the lung status, you monitor the hemodynamic status. So these things should be monitored regularly. So this is done only in a place that is called the intensive care unit. So where there is a dedicated staff working 24 hours there to see the patient's parameters and patient general condition and vital signs. So that is the ICU care. So there you monitor him, and as and when some changes are happening in the systemic organs, you treat them. If there is some cardiac dysfunction, you treat it. If BP is falling, treat it. If fluids are less, big patient is going into hypovolemia, treat hypovolemia. So you monitor it and treat accordingly. So that is ICU management, and monitor him whether he requires surgery or not. So I will tell you the indications of surgery just a few slides later. If there are CBD stones, you must treat the CBD stones. Management is essentially a conservative approach. So many of the patients, they need only conservative treatment. They don't require the surgical treatment. Aim to give rest to the pancreas, to treat the cause if possible, that is if gallstones are there, to monitor for local and systemic sequelae and manage them as and when they arise. The management depends upon the type of presentation and course of the disease. So all the patients are stratified into, depending upon the severity, 3 grades. One is mild acute pancreatitis. When do you call a patient in mild acute pancreatitis? When there is no organ dysfunction, when there is no systemic or local complications. So his complaint is only severe pain. Sometimes he may have vomitings. Then moderately severe patient. Here there may be organ failure that resolves within 48 hours and or local or systemic complications without persistent organ failure. So there may be local or systemic complication without the organ failure. Then severe means there is persistent organ, single or multiple, failure for more than 48 hours. So this is severe acute pancreatitis. So there are three grades. So mild grade, moderate grade, severe grade. Fortunately, about 80 to 85% of the cases, they belong to mild acute pancreatitis. Mild case, how do you clinically assess mild case? Patient is well, that means general condition is normal, that means all organs are functioning normally with normal vital signs. Severe case, patient will be severely ill with worsening physiological parameters like tachypnea, tachycardia, hypotension, subnormal or elevated body temperature, development of one or more organ failure, that means Ranson's criteria, or evidence of SIRS is present in 24 to 48 hours. So after the admission of this onset of the pain, 24 to 48 hours, within that, if we get any of these symptoms, then we should grade him as severe case. So what is the evidence of SIRS? When do you say a patient is having SIRS? SIRS is defined by presence of two or more of the following criteria. Heart rate more than 90 per minute, body temperature less than 30 degrees, 36 degrees or more than 38 degrees centigrade, respirations rate more than 20 per minute, PaCO2 more than 32 milligrams of mercury, total count more than 12,000 or less than 4,000. There can be leukopenia also. So by this we say patient is having SIRS. So if the patient is having SIRS, or if there is any organ, single or multiple organ dysfunction, or the patient is having hemodynamic disturbance or ARDS symptoms, so we consider him as severe symptoms. If these severe symptoms resolve in 48 hours, we call it as moderately severe case. If they persist or progress, we call it as severe case. So mainly we have two grades. Number one is mild patient, mild case, other is severe case. So mild case, what is the complaint? No organ failure, just pain, severe pain. So give rest to the pancreas and as well as to the patient. So and give sedatives and painkillers. Rest to the pancreas by doing nasogastric aspiration. So nasogastric aspiration means you pass a tube into the stomach through the nose, throat, esophagus, into the stomach. So the tube is called the Ryle's tube. So you pass the Ryle's tube and then go on aspirating. That means keep the stomach empty. So ask the patient not to take anything by mouth. Keep the stomach empty. That means all the fluid that is there in the stomach has to be aspirated. If the stomach is aspirated, then no fluid comes from the stomach to the duodenum. That means duodenum is not being stimulated. If duodenum is stimulated, again pancreas will be stimulated. So we want to give rest to the duodenum by doing nasogastric aspiration. Because you are not allowing the patient to take anything by mouth, you give the patients intravenous fluids for maintenance of the fluid balance. Then there are some drugs to inhibit pancreatic secretion. Somatostatin or its analog octreotide. It is a inhibitor for all the glands in the alimentary tract. So you can try this drug or glucagon. Then calcitonin, H2 blockers, aprotilin. So these are also tried, but none of them have been found to be of any use. That's why many centers, they don't use these drugs at all. Secretin is inhibited by PPIs. Secretin enzyme, the secretin hormone, it stimulates the pancreas to secrete lot of bicarbonate rich fluid from the pancreas. So the secretin is stimulated by acid in the stomach. So the acid when the stomach comes into the duodenum, the secretin is released. So that is why the secretin can be blocked by giving PPI indirectly. Observation and follow-up to monitor for severe disease. Because the patient may come to you in the mild stage, but later the disease may progress to the severe stage. That is why you have to properly monitor him for progress towards severity of the disease. Just here I will show you the functions of somatostatin. Its functions being inhibits gastric acid and pepsin secretion, inhibits pancreatic exocrine secretion, slows gastrointestinal transit time and inhibits absorption of glucose and amino acids, stimulates water and electrolyte reabsorption, inhibits tissue growth and proliferation, reduces pancreatic blood flow, inhibits gastrointestinal and pancreatic peptide hormone secretion, inhibits gallbladder contractility and bile flow, reduces liver blood flow, that means portal blood flow, as well as hepatic artery blood flow will be decreased by somatostatin. So it is a generalized depressant of the alimentary tract functions and vascularity. That is why we use this drug in variceal management also. In esophageal variceal management, hemorrhage management, there we have discussed about the somatostatin. So it reduces GI secretions and motility, reduces pancreatic blood flow. So this factor is taken into consideration and it is being used in management of variceal bleeding to stop or to decrease portal tension. So this is about treatment of mild case. The treatment of severe case. So managed in ICU. It is a multi-specialty teamwork. So you take the help of a physician, you take the help of an intensivist, you take the help of a nephrologist, etc., etc. As the organs are being dysfunctional, becoming dysfunctional, you take the help of those specialists concerned. Give broad spectrum antibiotics to prevent secondary infection, because when there is necrosis, it may get infected. So the infected necrosis carries a very, very severe and bad prognosis. If cholangitis or abnormal liver function tests are present, emergency ERCP and sphincterotomy is done to release the obstructed CBD. Intensive monitoring of cardiovascular, renal, respiratory systems are done and managed accordingly. Monitoring of hematocrit, clotting profile, blood glucose, serum calcium and magnesium and local condition is monitored by repeated CT scans. As I told earlier, so every 2 days you take the CT scan to see the progress of the disease in the pancreas. So how to treat the general complications? Shock. Already we discussed. What is the cause of shock here in acute pancreatitis? What are the causes of shock in acute pancreatitis? First cause. Yes, good. Hypovolemia. Why hypovolemia? Initially neurogenic, then hypovolemia, then sepsemia. Very good. Why hypovolemia? Tell me how the fluid is lost. Is it lost outside or lost inside or something else? What do you call that? Why hypovolemia is there? Why volume loss? Yes, very good. Third space. So it is loss into the third space. This is called third space loss. What do you understand by third space loss? Yes, whenever fluid gets sequestrated in the lumen of the gastrointestinal tract, peritoneal cavity, pleural cavity, and interstitial spaces of the tissues, that means extracellular fluid spaces, and as well as in the intravascular volume also sometimes it gets sequestrated. How it gets sequestrated in the intravascular volume? By profuse vasodilatation, generalized vasodilatation. Whenever there is, I told you about capacitant veins. So whenever there is capacitant veins dilatation, then there will be pooling of blood in these capacitant veins. So that leads to the third space loss. There is severe vasodilatation. Yes, you are right. So this capacitant venous dilatation can occur due to neurogenic shock as well as due to hormonal disturbance or due to sepsemia. So any of these things can cause this capacitant failure. That's one of the frequent causes of the hypovolemic shock in many of the surgical conditions. So the one first cause is neurogenic, then there is hypovolemia, either it due to sequestration of fluid in the gut or in the vascular spaces, or there is fluid in the retroperitoneal spaces, and lastly it can be due to cardiogenic. Whenever there is myocardial dysfunction, that can reduce cardiac output. So how do you manage these cases? First of all, there is volume replacement has to be done with crystalloids or colloids. But here this should be guided by central venous pressure monitoring or PAWP monitoring. Then most of these cases they are due to vasodilatation, pooling of blood in the capacitant veins. So they must be vasoconstriction must be done. So that's why you give inotropes. The inotropes they do not only peripheral vasoconstriction but also they stimulate the myocardium. So indicated if cardiac output is not maintained, even in spite of volume replacement. You give dopamine or dobutamine. Then ventilator support. You give oxygen by mask or by a ventilator, depending upon the PaO2 values and oxygen saturation. Monitoring of vital data, that means central venous pressure, PaWP, and arterial blood gas analysis. So the systemic complications. So first you treat shock by these parameters. Then nutrition. Nutrition is managed by giving intravenous fluids and TPN. What do you understand by TPN? What is TPN? Total parenteral nutrition. Very good. What are the indication for total parenteral nutrition in this case? Acute pancreatitis. Why do you want to give total parenteral nutrition? Why can't you just give IV fluids? Why do you want to give total parenteral nutrition? Okay, I will explain. You are giving rest to the pancreas by withholding food and fluid by mouth. So his nutritional status has to be maintained by intravenous fluids. What is the daily requirement of fluids? About 2.5 liters. So in this 2.5 liters, you can give in the form of dextrose plus 1 liter of normal saline added with potassium. So that will be sufficient for maintenance of fluid and electrolytes. Then what about nutrition? When you are not giving anything by mouth, you have to supplement by intravenous route. Just 1 minute, please. So you have to supplement by intravenous route. The amount of dextrose you give in the IV fluids is not sufficient to give nourishment to the patient because you give only 5% dextrose as replacement fluids. 5% dextrose means 5 grams in 100 ml. So you give 2 liters of fluid means you give roughly about 100 grams of glucose to the patient. So 100 grams of glucose means it gives only 400 kilocalories of energy to the patient. But the daily requirement of calories is around 1500 to 2500 kilocalories depending upon the weight of the patient. So you're giving just 400 calories, so that will not be adequate. So what will happen? His body stores will be depleted. So glycogen gets depleted, then fats and proteins will be broken down to yield energy to the patient. So for a well-built, healthy person, you can keep him on IV fluids only for 4 to 5 days. If you have to give fluids for more than 5 days means you must give him supplementation of glucose and amino acids and fatty acids by intravenous route. So the daily requirement of calories, daily requirement of proteins and fats, along with vitamins, minerals, and trace elements, they should be administered to the patient by intravenous route. This is called total parenteral nutrition. That means you are giving total nutrition requirement by parenteral route. So any patient who is on intravenous fluid therapy, that means giving rest to the mouth or rest to the alimentary tract for more than 5 days requires not only intravenous fluids but also total parenteral nutrition. Of course, we will have a separate class for that. If possible, you can do feeding jejunostomy after control of paralytic ileus. ARDS, if it is there, you have to give ventilator support. If renal failure is there, give mannitol and low molecular weight dextran and fluid electrolyte management. Renal dose of dopamine. If DAC is present, disseminated intravascular coagulation, heparinize the patient. Give fresh frozen plasma and platelets. If stress ulcers are present, you manage him by H2 blockers or PPI and sucralfate. So these are the general complications or general sequelae you find in the patient, and you manage them by monitoring them, and you manage as and when those symptoms or those conditions arise. Local conditions, acute peripancreatic fluid collection. So there are many local conditions which develop in severe acute pancreatitis. They are: number 1, acute peripancreatic edema or fluid collection. It is self-resolving and no treatment is needed. So you have seen on CT scan. So there is peripancreatic fat stranding. So when such is there, that indicates that there is fluid collection there. So it doesn't require any active treatment. If increasing in size or causing pressure on surrounding tissues or organs, you can do percutaneous aspiration under guidance. Sterile pancreatic necrosis. CT scan shows parenchymal non-enhancement after contrast injection due to non-viable parenchyma. It is not aspirated, and in 4 weeks it gets walled off with a fibrotic wall. Then it's called the walled off necrosis. If the patient shows local or systemic signs of sepsis, that means in form of severe pain, swinging temperature, tenderness, then it should be treated as infected necrosis. Treatment of infected necrosis. CT guided aspiration. So all the infected material, whatever that is possible, you have to aspirate it by passing a needle under CT guidance. And followed by percutaneous drainage with a wide bore tube. So once you do aspiration, you leave behind a guide wire. Over the guide wire, you pass a tube and leave the tube in the peripancreatic area where you have aspirated and give antibiotics to control the infection. The antibiotics should be chosen as per the culture and sensitivity report. If sepsis worsens, that means sepsis is increasing in spite of this tube drainage, then you have to do pancreatic necrosectomy. That means you do a open procedure or laparoscopic procedure and take away all the necrotic tissue in the pancreas. If the process of necrosis and sepsis continues, that means you have done necrosectomy today. Keep him under observation. Do CT scan again 24 hours later or 48 hours later. The necrosis has spread. Sepsis is increasing, but symptoms of SIRS will be progressing. That means pulse rate is increasing, total count is increasing. So then what you do? Then you do repeated CT scans and re-exploration is done. So again, reopen the abdomen. Then you do one of these following things. Closed continuous lavage. That means you pass two tubes into the pancreatic bed and you pass ringer lactate through one tube and the other tube is drained. That means continuously ringer lactate will be flowing through the pancreatic bed and it is draining out. So by the what you are doing, you are washing away all the enzymes and exudates outside without getting collected inside. This is called continuous closed drainage or lavage. Open packing. That means with ribbon gauze, you pack the pancreatic bed wherever you have removed the necrotic areas. Closure of the abdomen and re-laparotomy every 2 or 3 days. So every 2 or 3 days you open the laparotomy, do the laparotomy, and then take away all the necrosed tissue there. Associated gallstones are managed by cholecystectomy or cholecystostomy. Jejunostomy is added to the procedure to feed the patient. Usually, these patients who require this repeated laparotomy to remove the necrosed tissue, their prognosis will be very bad. So that will be around some 30 to 40% mortality is present. So they have to spend a lot in the ICU, and ultimately, in spite of spending so much to the hospital and then to the medicines, etc., they do not survive. And many of these patients, they have loss of their property because of their alcoholism. And once they land up in acute pancreatitis and they develop severe necrotic pancreas, infected necrotic pancreas, then their properties, whatever that's being left behind, will be completely looted. Then pancreatic abscess, that means if the infected necrosis becomes localized collection of pus, you got to give antibiotics plus percutaneous drainage with pus. Pancreatic ascites, interject necrosis and disruption of the pancreatic ducts into the peritoneal cavity. You drain the abdominal cavity by wide bore tubes. ERCP and pancreatic stenting is done to prevent leak from the duct. So you do ERCP and find out which place is leaking. So at that place, you pass a stent there so that the leak gets stopped. Sometimes there will be profuse or massive hemorrhage. It can occur into the gut, it can occur into the peritoneal cavity or into the retroperitoneum. The source of this hemorrhage is from a pseudo-aneurysm from a major blood vessel like splenic artery or gastroduodenal artery. So because of the enzymatic digestion, especially elastase, the outer walls of the arteries will be digested. So that causes weakness of the wall. So because of the weakness of the wall, there will be aneurysmal dilatation of the vessel there. So there will be no adventitia. The vasomedia is partially digested. So that pseudoaneurysm can rupture at any time. When it is by splenic artery or from the gastroduodenal artery, there will be profuse hemorrhage into the gut or into the retroperitoneum or into the peritoneal cavity. Then CT or MR angiography is done. Synaptic embolization, or if it is not available, surgery is done to ligate the bleeding vessel. So this should be done on an emergency basis. Other complication, local complication is portal vein or splenic vein thrombosis. So this presents as esophageal or fundal varices and are managed by conservative methods like EST. If coagulation profile is altered, it is corrected. So that is the management of severe pancreatitis. So severe pancreatitis is nothing but monitoring the patients for organ or system failure. And as and when you find any organ or system is functioning or dysfunctioning, then you manage it accordingly. The local complications like edema, fluid collection, necrosis, infected necrosis, the abscess, ascites, hemorrhage, they are monitored, and once they are discovered, they are appropriately managed. So that is the management of severe acute pancreatitis. So for pancreas, you are doing nothing. What is the treatment you are giving to the pancreas? Just giving rest, that's all. Some surgeons, they give some drugs which can block secretions of the pancreas, like octreotide or somatostatin, PPIs, that's all. There are only 2 drugs that are given. All the remaining things are the supportive management you give for the various organs and systems. So what is the role of surgery in acute pancreatitis? Just we will summarize. Number 1, in doubtful cases, to do diagnostic laparotomy or laparoscopy. Number 2, to correct the etiological factors like stone in the gallbladder, you can do biliary drainage procedure, either by ERCP and sphincterotomy or by cholecystostomy. This is cholecystostomy. To support the patient's nutrition, you can do jejunostomy, feeding jejunostomy. To manage local complications, necrosectomy, drainage of the abscess, peritoneal lavage. To prevent recurrence, treat the cause. Example, cholecystectomy for gallstones. Prognosis or mortality, mild cases less than 1%, severe cases 20 to 25%. So there will be 25% or more mortality in case of infected necrosis. So the treatment is very heavy, dependent on intensive care, and the cost is also very high, and survival rate is also very less. So the mortality is high. So this is about the management of the acute pancreatitis. So infected cases, there can be up to 50%. Any doubts in acute pancreatitis? If it is clear, we will go to the next topic, chronic pancreatitis. Chronic pancreatitis and acute pancreatitis are 2 stages of same disease process. A patient with chronic pancreatitis will have now and then the acute pancreatitis. Any doubts? Okay. I will now proceed to the summary of acute pancreatitis. Patient comes to you with acute pain, severe, radiating to the back. Investigation, serum amylase. If it is positive, go for CT scan. By these 2, you will diagnose it as acute pancreatitis. Once you diagnose acute pancreatitis, then severity is assessed by Ranson's criteria and clinical features. Clinical features means shock and organ dysfunctions. Ransom scoring. By this, you will classify it as mild or severe pancreatitis. Mild pancreatitis, nasogastric aspiration, IV fluids, analgesics, ERCP for CBD stones, CT scan after 72 hours if there is no improvement. So if the mild case resolves within 3 days, the patient is sent home. If he is having CBD stone, the stone is removed by ERCP. If there is no improvement or if there is progression after 72 hours, then you do CT scan to evaluate the stage of pancreatic inflammation. And if there is necrosis, then you call it as severe pancreatitis. Or if there is any organ dysfunction, call it as severe acute pancreatitis. So severe acute pancreatitis means you must be shifted to the place where intensive care management can be provided. So you give intensive care management and monitoring of organ function. Aggressive IV fluid resuscitation under monitoring of central venous pressure. Nasogastric aspiration, total parenteral nutrition, ERCP for CBD stones, CT scan again after 72 hours. No pancreatic necrosis. Continue the same treatment. Repeat scan if condition deteriorates. If pancreatic necrosis is there, that means the patient is going into complications. Give him prophylactic antibiotics, CT for gas in the pancreas, and guided FNAC for microbiological study. If condition deteriorates, then you see whether it is on FNAC, you will get the report, whether there is the presence of bacteria or not. If microbes are positive, that means it is infected necrosis. If they are negative, it is sterile necrosis. Sterile necrosis means the treatment is same. Continue same treatment. That means this treatment. Repeat FNAC if the condition deteriorates. If symptoms persist, do surgery. Infected necrosis, pancreatic debridement, drainage of the abscess, peritoneal lavage, you do it. Now we'll go ahead with chronic pancreatitis. Because you have not raised any doubts, I will progressing or pushing to chronic pancreatitis. Yes, if it is infected necrosis, in spite of giving antibiotics prophylactically, actually the prophylactic antibiotic, what antibiotic you give? Are you giving an antibiotic which is sensitive for the microbes that is causing infection? We don't know, because the infection can be due to various types of organisms like gram-positive, gram-negative, cocci, rods, and anaerobic bacteria. So what you usually give prophylactic, you give some broad-spectrum antibiotic. Probably that antibiotic may be sensitive for that particular organism or may not be. We do not know. Unless we do bacteriological study, culture study, we can't say whether that particular antibiotic is sensitive for that bacteria or not. So you empirically you start some antibiotic treatment, and that antibiotic may not be working against the bacteria. So if you do FNAC, if it is an infected necrosis, definitely you will see microbes. If your antibiotic is working, then there should not be any infected necrosis at all. Because then why do you want to give antibiotic then? So that is why many of the surgeons, they don't give antibiotics regularly without infected necrosis, prophylactically. They give antibiotic only when there is evidence of infection. That means you aspirate it, culture it, and by the culture report, you choose the antibiotic and you give that antibiotic. So that is the usual procedure that is being adopted. But some surgeons, because the patient is in severe case, his necrosis may progress to infected necrosis. To prevent that, they give prophylactic antibiotic. So that prophylactic antibiotic will work in few cases, and majority of the cases they won't work. So what antibiotic you have to give, that should be chosen only by aspiration and culture sensitivity tests. Yes, the peripancreatic area fluid can be aspirated by two methods. Under CT guidance, you pass it through the stomach. You pass through the skin, through the stomach, you pass the needle, and you pass through the posterior wall of the stomach, then reach the pancreas and then aspirate. Or else, you can do ESU, endoscopic ultrasound guidance. So you pass the endoscope with ultrasound probe, you keep it on the posterior wall of the stomach, see the where the edema or fluid collection is there, and you aspirate it by ESU. Necrosis will not cause any adjacent structures problem. The problem to the adjacent structures will occur because of the seepage of the enzymes and exudates. Yes, if the patient is having diabetes, recently detected diabetes after the acute pancreatitis, the patient should be managed only with insulin, not with any oral anti-diabetic drugs. After the acute pancreatitis subsides or resolves, then you have to check whether the diabetes persists or disappears. Sometimes patients may not be aware that they have diabetes because they never got checked their blood for sugar estimation. Yes, dextrose can be given even in diabetic patients with insulin. With that soluble or crystalline insulin, you give insulin. Mix in the dextrose bottle. You for every 500 ml of 5% dextrose, you add 5 units of the soluble insulin or crystalline insulin. Okay, we will go to the topic of chronic pancreatitis. Chronic pancreatitis is a progressive inflammatory disorder causing irreversible destruction of acini and ducts. So there will be irreversible destruction. Whenever there is a destruction of acini and ducts, they are replaced by fibrous tissue. So because of the fibrous tissue, there will be strictures in the duct. The strictures may be uniformly present or they may be present here and there. So when strictures are there at multiple places, in between the strictures, there will be dilatation of the ducts. That's called as sacculations. So this is associated with fibrosis of pancreatic and peripancreatic tissues with associated exocrine and endocrine insufficiency. Incidence common in males, age 40 years, etiology, idiopathic, then alcohol, 60 to 70% of the cases are because of the alcohol. Then ductal obstruction. The ductal obstruction can be due to following surgery or trauma, following acute pancreatitis, then due to pancreatic cancer causing ductal obstruction, then pancreas divisum and annular pancreas associated with papillary stenosis. So any cause of ductal obstruction, either mild or severe, can lead to retention of secretions and lead to activation of enzymes and causes pancreatitis. Then hereditary pancreatitis. Prematurely activated trypsinogen is inhibited by an enzyme called SPINK1. SPINK means serine protease inhibitor casal type 1 mutation and gets destroyed. So if any trypsinogen is activated in the pancreatic acini, this is inhibited, and if it gets activated, it gets destroyed. So it gets destroyed means there is no trypsin activation in the pancreatic acini. So that is why there is no inflammation of the pancreas. So the SPINK1 will be doing this job. If there is deficiency of this enzyme, then this can be pancreatitis. If loss of function mutation occur in SPINK1, it leads to pancreatitis. There will also be gain of function mutation in cationic gene on chromosome 7, leading to formation of degradation resistant trypsin. So by hereditary, sometimes there may be a gene that is called the cationic gene on chromosome 7 that leads to formation of degradation resistant trypsin. So this degradation resistant trypsin will be in activated form and causes pancreatitis. There is increased risk of cancer of the pancreas in the early onset type of the patients. So if the hereditary pancreatitis occurs in the early age, then there is increased risk of cancer. Then the other cause is infantile malnutrition. There's one more type called the idiopathic type. This type is seen in Kerala and is known as tropical pancreatitis of the Kerala. This occurs at an younger age. Incidence of stone formation, diabetes mellitus, and carcinoma pancreas are more frequently seen in this case. It is probably related to diet or genetic abnormalities. The staple food tapioca is considered as one of the etiological factors. Ingestion of cyanogenic glycosides in cassava and exposure to hydrocarbons released from kerosene and paraffin lamps are other possible causes in this case. Autoimmune pancreatitis, it may occur in association with other autoimmune disorders. So these are the various causes. So out of these so many causes, 70 to 80% of the cases are because of alcoholism. So the others being the hereditary, then autoimmune, then the tropical pancreatitis, then due to ductal obstruction. Then if you can't make out any cause, then you debit this case as an idiopathic case. Chronic inflammation. Leads to fibrosis of the ducts and fibrosis of the parenchyma. Fibrosis of the ducts leads to strictures and circulations. In the circulations, there will be formation of caliculi and there will be retention of secretions leading to exocrine deficiency. Fibrosis of the parenchyma lead to pancreatic calcifications, exocrine and endocrine deficiency. Sometimes there may be disease confined locally to only one part of the pancreas. So if there is fibrosis at the head of the pancreas, it can lead to occlusion of CBD by the fibrosis. This leads to cholestatic jaundice. Then fibrosis of peripancreatic tissues. So the inflammation will be there surrounding the pancreas also. This leads to pressure on the splenic vein, causing splenic vein occlusion, leading to fundal varices. So when we studied about the fundal varices, there also we have studied about this particular factor. Splenic vein thrombosis, isolated splenic vein thrombosis occurring in chronic pancreatitis can lead to fundal varices. What is the treatment for that? How do you treat fundal varices produced by splenic vein thrombosis? How do you manage? Splenic vein thrombosis. Of course, I am asking about surgical management. The simplest management is splenectomy. We need not do any shunt operation here. Once you remove the spleen, then why splenic vein thrombosis produces varices? This is the splenic vein. This is the spleen. It got thrombosed. what happens? The blood from spleen cannot go into the splenic vein. So it finds blood flow through the alternate channels. That means through short gastric veins into the fundal region and produces varices in the fundus. That's what is happening. So the simplest thing is you remove spleen, then there's no inflow into the short gastric veins. So the varices collapse. So to do a proximal linear shunt, all these things are not required. It is not due to portal hypertension. It is due to localized hypertension in the region of the short gastric veins because of this obstruction here. So splenic vein occlusion, fundal varices, so managed by splenectomy. Then there may be duodenal obstruction by peripancreatic fibrosis around the head of the pancreas. The duodenum may be strictured. And this chronic peripancreatic inflammation can also lead to pseudocyst collection. The chronic pancreatitis may be a diffuse phenomena affecting the whole of the pancreas, or it may be localized to the head, to the body, or to the tail of the pancreas. So here you can see this is localized to one head of the pancreas with stricture of the main duct in the head, leading to complete dilatation of the duct. Or it may be only the tail. So here the duct is strictured. That's why there is dilatation of the duct in the tail of the pancreas. Here there are multiple strictures with intervening dilatations. These are called the sacculations. So this looks as if there are lakes connected by a stream. So this is called chain of lakes deformity. So whenever you find multiple strictures with intervening sacculations, you call this as chain of lakes deformity. There is minimal changes. Main duct is normal, but side ducts, branching ducts, they have become dilated, ectatic, or fibrous. So this is not a uniform presentation. So some patients, they have lesions in the duct, some patients they have in the pancreatic parenchyma, some patients they have in the peripancreatic tissues. So there will be fibrosis, destruction of parenchyma, destruction of the ducts with these changes. Complications of chronic pancreatitis: pseudocyst formation, ascites, duodenal stenosis, cholestatic jaundice, splenic vein thrombosis, carcinoma of the pancreas. So these are the complications. Clinical features: preceding attacks of acute pancreatitis may be present. Pain is the main manifestation. Recurrent or continuous pain. Initially, it will be recurrent pain. After a few years, it becomes continuous pain. And this continuous pain gradually increases. And the pain radiates to the back, relieved with stooping, and aggravate with meal. And in this continuous pain, now and then the patient gets acute attacks of severe pain. The pain, if the chronic pancreatitis is localized to only one part of the pancreas, then the pain is also localized. Epigastric or right hypochondric areas for the head lesions, left hypochondric region for lesions of the tail of the pancreas. So usually what you see is many of the patients, they complain of pain in the back. They think that it is some backache due to some spinal disorder or due to paravertebral muscle sprain or strain, something like that. So that's what they do is they go on giving hot water fomentation to the back. So sometimes you find the lesions on the back like this because of the continued hot water fomentations. There will be history of nausea and vomiting, loss of weight due to severe continuous pain or due to malabsorption, steatorrhea due to loss of exocrine function. It occurs in about 30% of the cases. Obstructive jaundice due to obstruction to the common bile duct, then pseudopancreatitis, diabetes mellitus due to destruction of islets of Langerhans. Because in chronic pancreatitis there will be destruction of exocrine tissue as well as endocrine tissue of the pancreas. Investigations: serum amylase, it is elevated only in the early cases. So serum amylase function, investigation is not of much use. Pancreatic exocrine function test to confirm the presence of pancreatic insufficiency. What test you do? Tell me here. To evaluate the exocrine functional status of the pancreas, what investigation you do? Which investigation will help you to detect pancreatic insufficiency? What is? Tell me. Last time when I was talking to you about acute pancreatitis, one of you has suggested that test also. Yes, very good. Elastase. Where do you test elastase? In the serum? Or duodenal aspiration? Or somewhere else? Where do you test? Fecal elastase. Very good. Wonderful. You are right. So you examine for the fecal elastase test. That will tell you about the pancreatic exocrine function. Plain X-ray abdomen may show pancreatic calculi or pancreatic calcification. So you can see here the whole pancreas is having multiple calcifications, diffuse calcifications. So this is again another X-ray showing calcifications in the pancreas. Here again you can see pancreatic calcifications. Ultrasound scan abdomen, here also is not much useful. It may show thickening and altered echo texture of the pancreas. Ductal dilatation may also be seen. Associated pseudocyst, if it is there, can be identified. Here also the CT scan is very useful. With the investigation of choice, it will show the outline of the gland and areas of destruction and complications like pseudocyst, duodenal obstruction, splenic vein thrombosis. A normal CT scan doesn't rule out chronic pancreatitis because it may be a diffuse, mild fibrotic phenomena. So that may not be revealed on CT scan. So CT scan normalcy doesn't rule out chronic pancreatitis. Endoscopic ultrasonography. In chronic pancreatitis, it demonstrates the stones, visible side branches. Normally side branches are not visible, but because there will be ductal ectasia, the side branches are visible. Presence of cysts, lobularity, irregular main pancreatic duct with dilatations and strictures, and hyperechoic foci. So if these things are found, any of these things are present on EUS, we can make a diagnosis of chronic pancreatitis. If there are suspicious areas of malignancy, then endoscopic ultrasound scanning and guided fine needle aspiration has to be done. MRCP or ERCP to know about ductal anatomy. So it is the investigation for ductal abnormalities and help to determine the type of operation to be done to the patient. So this is CT scan showing a cyst in the tile So here the disease is confined to the tail of the pancreas. So when ERCP is done, you can see the duct is filled up to here. Beyond this duct is not seen. That means there is stricture in the duct here. That structure is also complete. That is why even a small amount of dye has not passed beyond this area. Tell me what is called this deformity? What is the name of this deformity? Yes, very good. It is chain of flakes deformity. When you know about the condition, when I make a question, so whoever knows the answer, they can mention. Only 5 or 6 are often interacting. The remaining, they are just keeping quiet. If you participate in the interactive discussion, you will be alert. And I will also be more alert because when so many students are responding to my questions, so I feel that all of you are actively involved in class listening. So I'll be more alert. So that is why if I ask any doubt or sorry, if I ask any question, then immediately please respond when you know it. Just don't keep quiet. Please respond, either right or wrong. Actually, if you commit a wrong answer now, you will never commit it in your life again. So once you present a wrong answer in the classroom, so that will be there in your mind and you will not repeat it again any time. Not only in examination, but in future also you will never repeat it. Here you can see a gross dilatation of the main pancreatic duct and also dilatation of the CBD. And there is some calcifications in the head of the pancreas. So there is ductal obstruction of the both bile duct as well as pancreatic duct. So investigations for a chronic pancreatitis. When the patient comes with chronic pain in the abdomen or steatorrhea or history of cholestasis, plain X-ray abdomen, you take it for calcification and calculi. Okay, now how is the voice? Are you able to have the audio normal or anyway, we'll just switch it off and then on it once again. I hope it should be fine now. Okay, that's fine. So a patient with chronic pancreatitis presents with chronic pain, steatorrhea, or cholestasis. Shruti, do you want me to show you the ERCP slide once again? Okay. This is chain of legs. I hope you appreciate that. That is multiple strictures with the circulations. Then this is dilatation of the pancreatic duct. Diffuse pancreatic duct is completely dilated along with dilatation of the common bile duct. So it is due to a mass in the head of the pancreas and which is calcified. So this is a head lesion of chronic pancreatitis. So this is the algorithm to be followed in a patient with suspected chronic pancreatitis. First you do for any patient with chronic pain, steatorrhea or cholestasis, plain X-ray abdomen for calcification and calculi. Then you do CT scan or MRI scan. Both of them, any of them can be done. CT scan may show dilated ducts. If ducts are dilated, definitely we have to go for ERCP or MRCP after secretin injection. Why secretin injection? Once you give the secretin injection to the patient and take ERCP, so secretin will cause secretion of it enhances the secretions of the exocrine pancreas, especially bicarbonate rich fluid secretion will be more. So when the stricture is there, when there is a lot of secretion, then the secretion can't go into the duodenum freely. So that leads to increased dilatation. So the dilatations in the pancreatic duct can be visualized very well by secretin injection. That is why before doing MRCP or ERCP, you just give secretin and then do ERCP. If dilated ducts are there, then do ERCP. If the ducts are normal, it may not be a pancreatic disease. So you're not dealing with chronic pancreatitis. Or it may be a case of small duct disease of the chronic pancreatitis. We have seen the chronic pancreatitis, the main duct is normal, but side branches only may have inflammatory changes. So this thing can be noted by ERCP or MRCP of secretin injection. So if the CT scan is normal or abnormal, go for ERCP. So ERCP, ductal disease is revealed. That means ductal dilatation is revealed. That is chronic pancreatitis. If the ducts are normal, then you do endoscopic ultrasonography with FNAC. That means for parenchymal disease. So you want to evaluate for the parenchymal disease of the pancreas. So ERCP will reveal only ductal disease. Parenchymal disease can't be revealed by ERCP. So go for EUS. If suspected lesion is there, do FNAC. FNAC is positive for malignancy, then treat it as carcinoma of pancreas. If it is negative, treat it like normal pancreas or chronic pancreatitis. So this is the algorithm you follow for diagnosis of chronic pancreatitis. And to exclude carcinoma of the pancreas, because carcinoma of the pancreas and chronic pancreatitis, their features and investigations in some patients may look alike. So to differentiate them, the only way is to do endoscopic ultrasonography followed by fine needle aspiration cytology. The management. Before management, because the disease presents in various forms, so the management also can be in various forms. For management, this is going to be classified into 4 groups or 4 types. Early disease, medical treatment is advised. Chronic pancreatitis with ductal dilatation or a calculus. Treatment is endoscopic management, or where endoscopic management is not available, you can go for surgical management. Fibrosed pancreas. That means the disease has burnt out. So whole pancreas has been constricted, fibrous. The treatment is medical management. Ductal narrowing. Difficult to treat by any method, and celiac plexus block may be helpful to alleviate the pain for a few weeks. So if there is diffuse narrowing of the side branches and complete duct is completely being narrowed, not like chain of lakes, the whole duct is fibrous, it's just like a string, then it is very difficult to treat by any methods. Then you have to go for only that patient will have severe pain that can be relieved by giving celiac plexus block. The medical management, the principles being abstinence from alcohol, pain relief. The pain relief can be done with non-opiate analgesics for the pain relief. Eliminate the obstruction in the duct. If obstruction in the duct is relieved, then pain can be subsided in majority of the patients, though not in all. Step ladder treatment of pain. So for any chronic intractable pains, either due to malignancy or diseases like chronic pancreatitis, you have to follow this step ladder pattern or step ladder treatment of the pain. Then intractable pain, you have to go for CT guided celiac plexus block. Do you know about step ladder treatment of the pain? For example, a patient comes to you with chronic pain which can't be treated, like cancer pain, advanced cancer disease. The patient will be having continuous pain. So then what analgesics have to be given, what treatment has to be given, that is guidelines were given by World Health Organization, that is called the step ladder treatment of pain as prescribed by WHO. So I will show you that step ladder pattern. So step ladder management of chronic pain, not only for chronic pancreatitis, any chronic pain which can't be cured by any surgical means or endoscopic means. Yes, you are right, Manognya. Step 1, give non-opioids like aspirin, paracetamol, NSAIDs, and adjuvants to analgesics like tricyclic depressants, gabapentin, or pregabalin. So they will modify pain reception. So first, initially give these things to the patient. For some days you give it. So the patients will be, if they are comfortable with this, you can continue with this. If they are not responding to this, then go to the next step. The next step is non-opiates and mild opiates like tramadol, codeine, dextropropoxyphene, plus adjuvants if required. So in this, what you're doing, you are going for tramadol also. Then step 3, if the patient is not getting any comfort with this treatment, then go for step 3. There you give non-opiates and strong opiates like morphine, fentanyl. This can be given as intramuscular injection or a skin patch. Now we are getting skin patches. Transdermal absorption of the fentanyl can be there, plus adjuvants if required. So this is the step ladder pattern management of chronic pains. So in chronic pancreatitis also, you follow this step ladder pattern of pain management. Nutrition support, diet, low in fat and high in protein and carbohydrate, because these patients get steatorrhea commonly, so you have to reduce fat intake. Pancreatic enzyme supplementation. In autoimmune pancreatitis, steroids are useful. Medium chain triglycerides in steatorrhea cases, as they are absorbed directly without any need for digestion by alimentary tract. And of course, here I forgot to mention you about vitamin A, D, K supplementation, because in steatorrhea, those are not absorbed. That's why you must. So vitamin A, D, K supplementation. PPIs, because when you give PPI, the acid output from the stomach into the duodenum will be greatly decreased. That is why secretin secretion also decreases. So when secretin stimulation is not there, there will be rest to the pancreas, so there will be pain relief. So there is medical management. Then endoscopic management indications: obstruction to the pancreatic duct, bile duct, or to the duodenum. Other indication is management of complications like pseudocyst formation, abscess, fundal varices, or ascites. Procedures: endoscopic sphincterotomy for papillary stenosis. For stricture of the pancreatic duct, stent across the stricture. For pancreatic ductal stones, they are extracted by ERCP. If they are large, they can't be extracted. Then you can use shockwave lithotripsy. That means you subject the patient to shock waves. So with the shock waves, the stones will be broken to multiple pieces. Then those can be extracted. Enzyme supplementation is given by oral route. You give trypsin and lipase by oral route as capsules. Immediately after taking meals, you can give those capsules. Then surgical management, indications, associated mass in the pancreas, ductal obstruction with dilatation, intractable pain with diffuse parenchymal disease, procedures for lesions confined to the head. So where they are intractable by medical means and endoscopic means, you go for surgery. So the treatment is pancreatoduodenectomy. So here you remove the pancreatic head along with the duodenum. So this part of the pancreas and head is removed, and there you can anastomose the pancreas directly to the duodenum, bile duct to the duodenum, and not duodenum, this is C-loop of jejunum. The rule loop of jejunum is brought up, and to that the pancreas, the hepatic duct, and the stomach are anastomosed. This is called Whipple's operation. Usually this is done in case of malignancy of the pancreas. We will discuss more in detail about it when we discuss about the pancreatic cancer. But here, for intractable pain where the lesion is confined to the head of the pancreas and medical management fails, endoscopic management fails, then you go for surgical management. Of course, you can preserve pylorus also. And about this pylorus preserving, pylorus not preserving, I will discuss when we talk about the cancer of the pancreas. For lesions confined to the distal pancreas, you can do distal pancreatectomy with or without splenectomy. So that part of the pancreas is removed. It may be combined with anastomosis of the resected body with a Roux-en-Y loop. That means when you cut it, then you can anastomose with a Roux-en-Y loop anastomosis. So then what happens is all the ductal drainage can be there from this side also. So when ducts drain well, then patient gets relief from pain. But whatever you do, the disease is a progressive inflammatory disorder causing fibrosis. So the patient develops strictures in other places, parenchymal fibrosis occurs, so the pain is not going to be relieved completely. The severity of the pain can be lessened. So that is why you must caution the patient before you do the treatment, give surgical treatment, that you are going to alleviate his pain, not completely relieve the pain. Marked dilatation of the pancreatic ducts, or multiple strictures with intervening circulations. Then the treatment is called longitudinal pancreaticojejunostomy. This is called Cousteau's procedure. This can be combined with coring out of the head of the pancreas. That means the superficial portion of the head of the pancreas is removed till the whole duct is being completely exposed. This is called the longitudinal pancreaticojejunostomy. You take a Roux-en-Y loop and you incise the loop, anastomose it to the opened pancreatic duct. That means you isolate the pancreatic duct and you cut open the pancreatic longitudinally. Anastomose this pancreatic duct to this loop of jejunum. This is called pancreaticojejunostomy. And you are doing to the longitudinal aspect of the pancreas. That is called the longitudinal pancreaticojejunostomy, also described as the Cousteau's operation. So if the diffuse dilatation of the duct or if chain of Lake's deformity is present, This is the operation of choice. For diffuse parenchymal fibrosis with intractable severe pain, then if the patient is fit, you can do total pancreatectomy. But if you do total pancreatectomy, you must supplement with exocrine and endocrine supplementations. Radiological management, CT guided drainage, percutaneous transgastric drainage of pseudopancreatic cyst. The patient comes to you only with obstructive jaundice but less of pancreatic pain, then obstructive jaundice can be relieved by biliary enteric anastomosis. That means you anastomose the gallbladder to a loop of jejunum like this. And the loop of jejunum will have anastomosis again at the bottom like this. Then what happens is the contents of the intestines will go like this without going into the gallbladder. The gallbladder secretions, they drain like this. This is called the cholecystojejunostomy. Carcinoma may develop in patients with disease of more than 20 years duration. So this is the topic of chronic pancreatitis and acute pancreatitis. If you have any doubts, I will clear them here. Any doubts, please? If you have no doubts, we will go to the talk of pseudopancreatic cyst in the next class. That is tomorrow. Pancreas is normally a very soft structure, but when it becomes chronically fibrous, it will be very thick. Sometimes it gets calcified and it becomes something like stone also. That's why this pancreas can be operated just like any other fibrous structure. When you give enzymes, they cause digestion and later they get degraded in the small bowel. So when you advise the patient to take the no, here in the pancreas there is nothing like calculation how long the patient survive. Actually, number of packets means how much of alcohol is taking since how long? Is that the one what you are asking? I think there is some calculation because it is not needed. I have not gone through that. So anyway, if you want it, I will check it and then I will let you know in the next class. Orally given pancreatic enzymes, they are coated, they resist digestion in the stomach. They are released only in the duodenum and small intestine. So once they are in the small intestine and duodenum, they do the digestion of the proteins and fats, and in latter part of the small intestine, they themselves get digested. They get digested by their enzymes itself. We can't replace pancreatic duct with other ducts, so we can place jejunum as a conduit to drain the pancreatic duct. So to remove the pancreatic duct from the pancreas means pancreatic duct means it is not a so pancreatic duct is not duct like this with lot of side branches. The side branches will have again tertiary branches. And these tertiary branches, they will be draining the isthmi and lobules. So to replace the duct means, which duct you replace? You have to replace the whole ductal system. When you replace the whole ductal system, you must have communications of this replaced duct with isthmi and lobules, which is impossible to make. That is why you can't take out this ductal system and replace with other. So the easiest way is to cut open this main duct and you anastomose it to the jejunum, so that all the strictures will be open. So this open tract will be draining directly into the jejunum. That will be the easier thing. I hope I am clear to you. So we cannot replace pancreatic duct. Is it okay? Okay, that's fine. Any more doubts? Okay. Okay, if you have no more doubts, I will close this session and we'll meet again tomorrow at 4 p.m. Okay? Wish you all good night. See you tomorrow. Thank you. Bye.